Hello, everyone. My name is Carissa Brewster, staff writer for Whitman Partners, and we are doing our perioperative powerless interviews for 2023. And today we are welcoming April Kranz, who is the VP of Patient Care Services and the CNO at Conway Regional Health. Welcome, April.
Thank you. Appreciate the introduction.
You're welcome.
I think the way that we attract and retain staff has changed drastically from pre-pandemic to post-pandemic. So post-pandemic, we're focusing on cultural reset is what I call it. So cultural reset means we're putting the well-being of our caregivers first. We're giving them some training such as a program that's called Candor. So it's a debriefing session for people, specifically caregivers that have gone through traumatic events, to be able to help coach each other and guide them through that. Pre-pandemic, you wouldn't have seen that type of training in this situation where I'm at, or at least we didn't see it at my organization. And we've also focused a lot on new grads. Pre-pandemic, it was pretty easy. You could go out and you could find nurses that had a year or two of experience. You could put them on a floor and life was great. You could put them in the OR setting wherever you wanted. Post-pandemic, it gets a little challenging. So we actually have to leverage those partnerships with our academic partners, and we created nurse residency programs for our new grads. So there isn't an area in this hospital that you can't be a new grad and be placed in. So pre-pandemic versus post-pandemic, that's kind of how we're attracting our new staff, is being new and innovative, but then how we're retaining them and hiring them is, I think that our organization specifically has a huge focus on well-being, and that's something that every caregiver is striving for at this time.
Right. And has it traditionally been difficult to get into peri-op, in past decades? And is that still the case now?
It was, and I think it was difficult because there is kind of this misconception that you should have some experience either as a staff nurse in a physician office, wherever that may be, before you come into the OR setting. But there are really good programs. AORN has a Periop 101 program that is specifically designed for a nurse residency program for Periop. We can take our new grad and we can give them the skill set so that they can think critically, even though they haven't had that experience on a floor. So we do see that changing now, especially in my organization, and then previous ones I've been a part of. You have seen that shift where new grads are welcome in those areas. Well, I found it surprising that everyone is interested about peri-op. So the inpatient directors, your quality department, infection prevention, but there are times when we put up barriers in the surgery and say, well, this is surgery, you may not understand it, but they always want to understand it, and they can actually be our better partners, and we can have this intercollaborative relationship where we're improving population health overall if we invite them into surgery. So it was very interesting for me as a VP to know that it isn't that you don't want to be a part of it. I just needed to be more welcoming. So having those relationships and knowing that the desire is there has kind of changed the view of how we view surgical services. Instead of being segmented and siloed from inpatient care or from the overall care of a patient, it's one piece of the puzzle.
That's kind of interesting because basically what you're saying is that you're surprised that the higher ups are interested in what's going on in peri-op when you're there working with them.
They are. They're like, oh, I didn't know that. And I'm like, well, let me tell you all about it. And honestly, you're welcome to go view it for yourself if you'd like. They're very curious. They just needed the invitation.
Yeah. That's an interesting way to look at it, because I know for some people they literally may not be interested, but you're saying there's probably people out there that are interested and they just kind of need a welcoming hand, essentially.
That's all I need.
Yeah.
I did. I've always had either a formal or informal mentor. So my formal ones are, I would ask for leadership coaching, and there's a company specifically that I've used for a few years that I'm placed with currently, even at my VP level. So this could have been manager, director, and above in that leadership. In those informal leaders, they were peers that I would connect with and say, okay, you've done this in surgery. You were a great operations leader. Help me understand this. But then some of them were outside of my discipline. So I actually sought mentors that were in like respiratory therapy or pharmacy, so they could tell me what the perceptions of surgery were. And so I could break down some of the barriers that maybe previous administrations had either put up or broken down that they wanted back, things like that. So formal leadership training, yes, I've had a lot of it, and I currently still have that. Informal, I think we cannot undervalue what that is as well, because those are your peers and your colleagues telling you how you can improve.
Yeah. So you said you're still involved. Is that as a mentor or a mentee or both?
But because leadership is a journey, not a destination. So I have to give back. I'm finishing my doctorate right now in executive nurse practice. So I have a lot to give back as a mentor, but yet I'm also learning as a mentee. So I have both of those. So I do some mentoring through my college that I'm associated with, and then through my professional affiliations, and I still get coaching myself.
What is that like? Because I would think people might just, if they're not thinking about it, like a VP, how does a VP need coaching? Like, tell me a little bit about what that's like at your level.
When you get to the VP level, you've already proven your skill set either through a certification or through, your resume, how you kind of climbed the ladder in some way. So from like a clinical operational standpoint, you are the expert. But there's normally like this gap that exists between what the role you had and the role that you're going to have, and it comes down to people. Are you able to navigate people? Are you able to navigate politics? What should it look like at a VP level for nursing? Overall, at a director level, I wasn't going to a state house and advocating for legislation that would change and impact nursing. Specifically in this instance, we can talk about surgical smoke evac for periop. As a director, I had the opportunity, but I didn't really understand it. As an executive, it's expected of me. So that's the difference in why that leadership needs to exist there, why the coaching does. Because how do you get from step A to step B if you've never had the coaching or the guidance? I have, yeah. I can tell I'm a little bit younger and not as seasoned as what some of the leaders may be. And so I am in that millennial, workforce that says, I don't necessarily want to work nights, weekends, holidays, and I want to put my family first at sometimes, or maybe it's my friends or my dog. So that has changed my perception. When we went through the pandemic, we really realized what's important. So when I talk about the cultural reset that's happening in Conway Regional, it's not just Conway Regional and it's not just Periop overall, but for me, I had to step back and say, you can't meet your goal without people. And so that means you have to give people what they need. And at this time, maybe they need you to value the birthday of their dog on the same level as the birthday of their child. We didn't look at it like that from healthcare. We never did. And so instead of saying, oh, this is just an entitled group of people, or this is how these people are, it's more or less, no, this is how society has changed, and this is our new values. So the values of organizations you've seen change. Ours has not at Conway Regional. We've just put an emphasis more on that compassion aspect of it and the excellence, because someone coming to me saying, I don't want to work weekends, or I don't have the availability to work weekends, doesn't make them a bad nurse, CST, whoever that may be. It just means that they have some boundaries and some conflicts, but they still want to be a part of my organization. Prior to COVID, I might have said, let me help you transition to a new role. Past COVID, I'm now saying, okay, let's find some hours and some shifts that work for you and the organization. I think everyone can critique every leadership role they step into, the administration that you're following, whether it's, good, bad, or indifferent. There were probably opportunities no matter what. So when I stepped into the role I'm in currently, there are some financial barriers that were there. And I think that's with every healthcare system. So how can we be better, but with less resources? That's an extreme challenge. And you don't see it any less in surgery. And so you have to start reaching out to your colleagues, your peers, and saying, how have we done it other places? Could we implement those here? Could we not? My biggest challenge here at Conway Regional and specific to the perioperative area was connecting our finance person, our chief financial officer, to the OR and understanding how the staffing looks different, or what I was proposing, which is a budget that's backed by AORN. How does that align with where he needs to be financially? Because I was trying to staff more people in that area. And so you have to align those things and really give them the deeper understanding. But I think that every role you step into as a leader, there's always going to be challenges no matter what, because you are looking at it from a different lens than what the previous person did. You look at it as an opportunity. So when we look at cutting costs and improving efficiencies, things like that, and driving more revenue, people are the last thing that I ever look at cutting. Now, I do look at, are we staffed right to begin with? So understanding that a budget was built correctly and that the people that we have are the people that we need to do that service, I start looking at the products that we use. Could we capitalize on contracts a little bit better? I also start looking at from a system level of what are my sister hospitals doing that are a part of my GPO, a part of my purchasing power. Maybe we all need to get together instead of remaining siloed and start talking about the services, the products, the equipment that we're using. And now we can capitalize on better contracts. So for example, a C-arm, if I was going to pay $100,000 for a C-arm and just buy one for my hospital, well, what if the other hospitals need one as well? So now we're buying 5. So now instead of being 100,000, they're 80,000 a piece. Looking at things like that is how we're really going to start to save money in this financial crisis without sacrificing people in the background. So services, contracts, and breaking down silos are where we need to be.
Yeah, would you say that the area of underutilized products is that something that is overlooked or has been overlooked in the past?
I think that we overlook some of the things. If we talk about surgical services, has a lot of their supplies that will reside in what we call packs. So you have a pack in a room that you would open and it has 100 different little widgets inside of it. But if you don't use 5 of the widgets routinely, then that's an area for cost savings. We can go ahead and start removing some of those. So involving your staff members and really getting them to understand is one aspect of it. But the second part is engaging our physician partners. And I think we might overlook that at times. When your physician partners know where you're at from a financial standpoint, and they understand that the goal is to retain the people so that they can give the quality care they're looking for, they're more than likely going to give up their widget that costs $500 more than a separate widget that doesn't, if they understand that what's on the line is people or product. I've had great conversations with physicians about that. I've never had a physician choose the product over the people at all, ever. And then I've actually got some really good conversations from them about being engaged in their own packs. And they say, I know that I don't use this, and I know my partners probably don't need it. So let me talk to them and let's make it less. So we almost run like a lean metric or a lean process through those packs and those widgets. Visibility is it's a double-edged sword there. There's what I think visibility is, and there's also what visibility actually is to you. So if I come through your unit and I have a meaningful conversation with you, and I only do that once a month, you might say, April's always around. She's always there when I need her. She's taking care of it. Versus if I come through your unit every other day and I never fully engage with you. So what I do is I set an expectation with my staff members, and at this point as a VP, I set it with my directors. Tell me what your unit's expectation is of my role. How has it functioned previously? How would you like to see it function? And then we kind of work that out. So it doesn't look the same for all of my areas. I may put in a lot of effort and walk through this unit 10 times a day. Not really, because I don't have the time to do that, but I may walk through it more frequently than another unit that says, I really just need for you to check on me on Fridays because that's when our volume is insane and I need you the most on that day. So visibility is about setting that expectation and understanding what the unit need is to begin with. And then you should never have a problem with whether you're visible or not, because if I think visibility is 2 times a week and you never thought that that was 2 times a week, if you didn't agree with it, we're never going to meet in the middle ever. We're never going to get to the goal we were trying to accomplish. Yeah, I was really excited to share this. There's a committee that the idea came from me, but I cannot say that the creation was solely me because it wasn't. It took a whole team to do it. And there's something that we created called SSI committee. So Surgical Site Infection Committee. It's a multidisciplinary committee that takes the surgical site infections for the different service lines, and it invites it as a part of a conversation. And it treats all of them in each service line like an opportunity. So in this group that gets together, the focus of the month may be ortho. And so we talk about the ortho SSIs that have happened. We invite the physicians to be a part of it to speak. We invite the service line leaders, which would be like coordinators in this role. We also invite the quality people. We invite pharmacy to talk about the antibiotics they received, the nurses who were involved in the pre-op care, the nurses in the post-op care. And then we also invite the floor that they went to. So this could be, maybe they went to your 3rd floor, which is med surg or post-ortho care or post-ortho surgery care. We would invite that leadership team to come with the expectation that everyone before they come to this meeting has done a deep dive into the chart to speak to their specific area of care. And the greatest thing that comes out of this meeting is that sometimes we find nothing and we figure out that the care that we gave was amazing and that this patient was maybe non-compliant at home or had the potential, but we didn't recognize it in the hospital. That's amazing. But then the other thing on the other side is when we do have an opportunity, now it lives with accountability. So that team will come back and they will reconvene the next month. They'll go ahead and bring all their follow-ups from what they were doing and kind of what that led to. And so the accountability factor is we are making process changes. Physicians are saying, maybe I need to change the prep I'm using. We've got pharmacy saying, well, maybe we need to put up antibiotic guidance up in the OR rooms instead of just putting it on our EMR system. That is probably the biggest accomplishment I can say, because to get a group of people of 10 different disciplines to get together and agree in one direction we should be going, that's a huge accomplishment.
Great. Thank you so much. That was a great interview. Thank you so much for joining us today.
Yeah, I appreciate you. Thank you.